if you look at the title, Association of Treatment Dose Anticoagulation with Survival, I think it's very kind of a sexy headline that seems like, okay, this is really promising. And we know that there is clotting happening, but let's just look at the paper in a little bit more detail. So it was just a research letter, and so that had an 800 word limit, so there's very little information that the authors could include in that amount of time or word space. It's observational, and what they did is looked at, retrospectively looked at their 2,700 plus patients pretty much for the end of March and beginning of April. And what we don't know is that they said that 28% received therapeutic anticoagulation, and the other group was kind of the quote anticoagulation group, but we don't really know if that meant prophylactic or completely nothing. Again, they didn't have time and there's no appendix. And one thing to note is they had a median time to initiation of the therapeutic anticoagulation of 2 days with a range of 0 to 5 days post-admission. And their outcome was for this Cox proportional hazard ratio for in-hospital mortality. And they did do some adjustment based on these demographics and risk factors. Okay, so what they found is if they looked at all the 2,000 plus patients, there was no difference between the full anticoagulation group and again what they call the no anticoagulation group, which I don't know means prophylaxis. So there's no difference in all patients. But they had a subset of patients that went to the ICU and were mechanically ventilated, and quite a few of them actually. And in this subset, the anticoagulation group had a very staggeringly high improvement in mortality from 62.7 to 29.1%. And they said basically that's an adjusted hazard ratio of 0.86 per day of anticoagulation received. So statistically significant, and looking at it grossly based on the numbers, it's very, I think, compelling. But then there's some things that we're going to look at in the details that may make it a little bit more hard to kind of take this information and run with it. So one thing is here's the same data, but just kind of over time in one of these Kaplan-Meier curves, and you can see the orange color that there's definitely a big gap between the two groups. But interestingly, if you look into the paperwork, the groups also were different. They just said a group of people that had anticoagulation, but almost 30% of them actually required mechanical ventilation, whereas the non-anticoagulation group, only 8% of them required anticoagulation. So something strange there, and you would probably say this is completely a random fluctuation, because why should being on full dose anticoagulation cause you to get mechanical ventilation? But it was, again, I think a staggering difference between the two groups. They didn't give us a hazard ratio for this one. And then there's something called Immortal time bias that you should always think about in a cohort study. And basically, if you remember back to, they said the median time to initiation of the anticoagulation was 2 days, and it ranged up to 5 days. So what happens is if anyone dies within that period before initiation, they actually get counted as the no anticoagulation group. So any mortality in that first days and ranging up to 5 days could unfavorably make the non-anticoagulation group look worse. So if we go back to this chart here, if you look at where 2 days is and where 5 days is, you can see that there's already a gap starting to form there. So there's still a difference later on, but we don't know how much that kind of shifting the group size to the non-anticoagulation group had a difference. Another thing is that the way Sinai set this up is their protocol was just before they kind of did this study is that all patients that came to the ICU were going to receive full anticoagulation. And so the non-anticoagulation group is really the group that didn't receive full anticoagulation because they had some kind of contraindication, because they would have wanted to, by protocol, give them anticoagulation. And so what we're comparing is a group of people that could receive anticoagulation to a group of people that could not receive anticoagulation. And we already know that there's plenty of things that we know are risk factors for bleeding that could be potentially why these people had a contraindication. And so here's just 2 scoring systems that we know about, IMPROVE and HASBLED. And what I scratched out here is all the things that they adjusted for in the Cox hazard ratio. but you can see how many things are not adjusted for. And these are all my speculation and other people's speculation reading about it online. But since it's an 800-word document, we really don't know anything about the patients. But you could imagine that a group of people that has a contraindication to anticoagulation, I think would traditionally be considered a pretty high-risk group in general because of whatever comorbidities or whatever active disease or active bleeding they have to make them have a contraindication. So I would say, the title, I think, is gives us something that we think there's something really strong there, but I have no idea what no anticoagulation means. We don't know if it's prophylaxis or completely no anticoagulation. If you would accept the supposition that the survival was in the ventilated patients was driven by anticoagulation, then does that mean you accept that the actual increased need for ventilation was also driven by the full dose anticoagulation? We talked about Immortal time bias, and then we have no idea which are the comorbidities in the non-anticoagulation group. And so we can't say anything about, is that a sicker patient population or what? So the authors themselves, they have a lengthy statement about what are all the limitations. And so I think they're not, besides the title, I think they're not, and actually in the title they say association, so they're not saying causation or anything. But I think when you see in the Washington Post and other media outlets, and they're saying, this could be, it gets out there very quickly, and then all of a sudden you have people saying, should this be standard of care? When really, I don't know if it advances kind of what we know about the disease, even though we know there's coagulopathy. We talked before in the previous talk, do we know that this is going to be the answer, or is this driving survivability? So the answer, again, is always going to be doing a trial. And just a reminder that there's going to be a couple of trials coming online here in Georgetown. One with Dr. Broom that's starting, I think, next Monday, and another one shortly thereafter with Drs. Kessler, Montero, and Dr. Cardella.